Hi everybody, Johnny and Paulina here, and we are looking at the posterior Talar glide test. What this test is, it is looking at a positional fault of the talus. So, this research comes from manual therapy research, so mainly from Australia and Mulligan. And the talus, it's an amazing bone. Does a huge amount of stuff with regards to straightening out forces from the lower leg and then taking reactive forces from the ground upwards, and it helps us to move forward. So, if we've had disruption or injury to the ligaments around the talocrural joint, so the talocrural joint being your fibula, tibia, and your talus, sometimes because the talus doesn't have any muscular attachments, the theory is that the talus can move forward and downwards. So it can, in effect, it can sublux. And according to the researchers and manual therapists, that the talus stays anteriorly displaced. So it's an anterior subluxation. So it's a positional fault of the talus until it's manually put back into its position. So that takes us to the part of, well, how do you know it is anteriorly positioned? So this is where the posterior Talar glide test comes in. So you can see that you've got your patient sitting at the edge of the bed and the thigh is firmly fixated on the back of the bed here. Now, the test all revolves around a degree of knee flexion. Okay, so what you would have here is an inclinometer on the tibia here. I haven't got one at the moment. It's COVID-19, so normally I would have one there. So my inclinometer looks pretty much like this, and what I do is I place it just below the tibial tuberosity here. Now this is normally strapped to the patient with a Velcro one. Okay, so one of the key things here is if your patient has a restriction in dorsiflexion following a lateral ankle sprain, it may be due to a malposition or a positional fault of the talus. The talus is going forwards, and for dorsiflexion to occur, the talus has got to slide backwards within the joint. So if they've got restricted dorsiflexion in comparison to the other side, then it may be because of this. So the test then, as I say, is the posterior Talar glide test. So got the patient, as we said, sitting firmly fixed there. The knee is bent to 90 degrees. What's going to happen now is that I'm going to make sure that the foot is in neutral. So it's perpendicular to the floor, parallel to the floor, and it's also in subtalar neutral. I'm going to get the plantar surfaces of my thumbs, and I'm going to do a anterior to posterior glide of the talus within the mortise. I do that because I'm going to bring the foot into dorsiflexion at the same time. I should feel a firm capsular end point, and then what I can do is I can then check that to the other side. If there's a restriction, then you might use some MWM, so movement mobilization, so Maitland technique or Mulligan's technique with regards to this. So how it works is that patient is fixing like this. I'm going to make sure that the foot is in a neutral position. Subtalar is neutral, so she's not adducted or abducted or inverted or everted. I'm going to grab the foot, both hands around there. My thumbs are going to be just in the joint line. I'm giving a posterior glide, and it's dorsiflexing the foot at the same time. So right in the joint line, and there's my push. And then what I can do is there's my firm end capsular feeling. So that talus is not going back any further than there. A little bit restricted in dorsiflexion on this side with Paulina because she's had a previous injury on this side, haven't you? So it's easy for me to see on this side, because when I do it with the opposite side, so I get her into, again, parallel to the floor, subtalar neutral, thumbs on the anterior aspect of the talus, and then I've got a much more, so I can feel a lot more movement with that talus gliding back in the joint. Problem with all these stability tests, these clinical stability tests, is it depends, it's an art, and it depends on the experience of the clinician. I'm not saying I'm an artist, by the way, but it's very subjective. So how Paulina might do it and how I might do it, there might be a difference in strength, there might be a difference in technique. It's very subjective as well. So am I actually feeling that, or am I thinking myself into feeling that? So they have some validity and reliability aspects to them. All of them do. The anterior drawer test, the Talar tilt test, this posterior Talar glide test. This is my least favorite out of these clinical stability tests, because I'm not sure I can feel very well that posterior glide of the talus within that talar-crural joint. Theoretically, I get it. And if I was Mulligan or Maitland, maybe I'd be a lot better at this than I am at it. But if I've got a restriction in dorsiflexion, if I've got a patient who's got a restriction in dorsiflexion, I would tend to use a posterior glide, movement mobilization of the talus there, and that tends to kind of to help with regards to dorsiflexion. Does that mean that I believe that it's a positional fault of the talus that had to be manually put back in? I'm not saying it's wrong. I'm just saying look, the jury's out for me. I think a lot of things going on. You're going to have local changes because my hands are on the joint. You're going to have where this is in correlation to the spinal segment and supraspinal. You're going to have some changes. How I deliver my message to the patient is going to change. So if I believe it, then the patient might believe it. If I see a change or an improvement, then the patient might do. So there's a lot going on here. But certainly as a physiotherapist, I think it's a good examination to know. If you've had a patient who's a lateral ankle sprain and they've got a restricted dorsiflexion, you may want to look down this route of seeing is there any restriction in a posterior glide of the talus. So hope you enjoyed the posterior Talar tilt or posterior Talar glide test.